My assumption is that all adults will be familiar with blood transfusion. Whether you are a physician, you are a nurse, medical student, or nursing student, we are all in one way or the other familiar with blood transfusion. And if you are not in health field, if you have never received any of the blood products, probably someone close to you would have in the past or even right now. So I don't know how much you've known about blood product transfusion and how much you want to know. But looking at this, you are familiar with this, right? Red blood cells. Many people would think anything about blood transfusion will have to do with red blood cells alone. No, that is not the case. There are many products here that could be transfused, all still under the same umbrella, blood products transfusion. Without further ado, let me welcome you to this channel. Thanks for visiting my channel. If you haven't subscribed, please kindly remember to do. But if you have subscribed and you are visiting again, I'm saying a big thank you. So, blood product transfusion. Let's go. Okay, if blood is taken from your body and is put in a tube and it is centrifuged, this is what you are going to find. The lowermost part will be red blood cells, and that's about 45%. The uppermost parts will be plasma, that's about 55%. In between the two will be the buffer coat. That's pretty small, about 1%, but pretty important. That's where we're going to find the leukocytes and the platelets. We have to do everything right. The intention is to save life. Whether you want to stop bleeding or you want to transfuse red blood cells because of anemia or you want to give immunoglobulin, anything you want to give, we must do it rightly. If not, the intention of saving the life could then be the other way around. The life could even be lost while giving the blood product. So, right blood product to the right person that needs it, given at the right time, and where? At the right place. The first note I'm going to leave here is that we're going to be going through many things here, but the outcome or the goal will remain the same, so the same expectation. So we'll go through many different products for different types of patients, for different reasons, but with one goal, the same sound health as the goal. Now, appreciation to all blood donors worldwide. In many countries, it's free. In some parts of the world, you get paid. Actually, some that are anemic will actually give blood in that part of the world just for the money. But to those who are giving this for free, I'm saying a big thank you. Even those who are getting paid, still saying thank you also. Now, two people with the same hemoglobin level or hematocrit level may not be treated the same way. Why that? In a bit. One may be transfused with packed red blood cells, while the other won't be. And they may receive different products. Some will need plasma, some will need platelets, another will need red blood cells. Less of whole blood transfusion nowadays. In other words, we don't give whole blood so much anymore, particularly in advanced countries and in advanced centers. Why that? My presentation is expected to go around the whole world. So in some parts of the world where they don't have the equipment for apheresis, for separation of products into different layers, they still give whole blood. Some will be transfused even with hemoglobin or hematocrit within the normal range. That is not likely going to be red blood cell transfusion. So somebody is having the correct or within the normal range hemoglobin or hematocrit, yet he or she might need platelets, might need constituent of the plasma for one thing or the other. We'll go through them in a bit. Before delving deeper into transfusion, we must know certain things before hooking the blood up and running it into that man or woman. We must have the basic knowledge of ABO blood group and resource. We must determine the compatibility or the incompatibility that will determine whether or not we will proceed with the transfusion or we look for another product entirely. So those who are in group O, we call them universal donors. They can give to everyone, but they can only receive from O, from their own family members. I mean, those that are in the family of O. The O negative female, either a child or a woman of childbearing age, should not receive from O positive donor. Why that? I will explain further in a bit. But if you're in a hurry to get the understanding of why a young lady and all women of childbearing age should not receive from O positive, even when they can receive from O, but it's not advisable that they should receive from O. If that is the case, particularly O negative females, all of them, I'm not saying postmenopausal, then you can click on this very link. Here you understand the relationship between pregnancy and resource D problems. AB is known to be universal recipient, meaning they can receive from anybody, from group A, B, AB, or O. But A can only receive from A and O, while B can only receive from B and O. But when it comes to compatibility as per plasma types and frozen plasma and cryoprecipitate, we have some flexibility. But when we reach there, I'll bring that out. Still, before transfusion, if you are faced with emergency situation and you must transfuse without grouping and cross-matching, that's still possible, but the options are not many. All negative blood can be given without grouping and cross-matching to all girls and all women of childbearing age. All positive blood without grouping and cross-matching can be given to all males, boys and men, and all post-menopausal women. Why that? It's all about the relationship of pregnancy and resource D problems. If you want to quickly get the full pieces of info about that, you can click on this very link. Now, in many parts of the world, you must follow the rules and regulations in your jurisdiction. In some parts of the world, the doctors are the decision makers. They start and finish whatever they want to do without actually seeking the input from the patient. Some will not believe this, but that is the way it is. So, go by the law of the land, legal aspect of blood transfusion. You must take your decision with the patient or substitute decision maker, and in the case of children, with the parents. There must be a signed consent after thorough explanation for the reason or reasons for the transfusion of the type of the blood product that you want to transfuse. We must explain the possible side effects and report all transfusion reaction or reactions very promptly. We may see court order depending on your jurisdiction and what can be done in your state, province, or municipality if the parents are not acting, and you suspect this is not in the best interest of this child, or the substitute decision maker is not acting in the best interest of the patient who can no longer take decision right now, you may proceed to court to get court order, but it depends on what is obtainable in your jurisdiction. So why is this legal aspect pretty important? Well, in Jehovah's Witness, their doctrine, they will not tell you that they don't want blood transfusion. Let me share a brief story here. There was a good doctor in one of the advanced countries. He was trying to help a Jehovah's Witness, and it was a case of accident, and he went ahead and gave the blood and transfused. When the Jehovah's Witness person was out of the related issue, the doctor got sued. And you won't believe it. Well, it should be the Jehovah's Witness patient that is now healthy, sued, and won. Yes, it's a true life story. Without consent, in medicine, it is battery. So don't be guilty while trying to be kind, while trying to save lives. Legal aspects must be routinely and rigidly followed. Before embarking on transfusion of blood products, we should think about other measures that we can take without using the blood products. That's all I meant by alternatives to blood transfusion. And in that case, Jehovah's Witness worshippers, members will have less problem with you, and any other patient that will not want blood transfusion. So we must consider the whole health status of the patient, then decide whether or not there are other ways to go about it without giving the blood products. So the next 4 slides will take us through alternatives to blood transfusion. Okay, the alternatives to blood transfusion will take me to iron. And the first thing to consider here will be iron-fortified foods or healthy foods rich in iron. And you can find that with shellfish, beef liver, soya beans, lentils, the beef itself, oats, dark chocolate, prunes, beans, peanut, kale, flaxseed, pumpkin, and the list goes on. Then if that is not the case, and if the individual had taken the iron-rich food or is not rich enough to do that, you can go for iron supplements per oral. And that will include ferrous sulfate, ferrous gluconate, ferric citrate, and ferric sulfate. And that could be taken as salt or a liquid or in form of pills like capsules or tablets. The intravenous iron, that will be necessary if we cannot win with these 2 above, okay? Or under certain situations. I will go into that in a bit. Here we can make use of iron dextrans, sodium ferrigluconate, ferromositol, or iron sucrose. We have to be careful with intravenous iron, yes, particularly as per the anaphylaxis. And on this list, iron dextran will have the worst reaction as per anaphylaxis, while iron sucrose will have the least reaction. It is better to give these with erythropoietin in case of renal failure. Why is renal failure a big problem leading to anemia? Well, the kidney is helping us. Although we still come across this in the course of this presentation, the kidney is helping us to produce erythropoietin that is helpful in producing blood cells through the bone marrow. When the kidney itself is in trouble, then the level of erythropoietin will be down. And of course, its function will then become impaired. So it is better than oral iron. I mean, intravenous iron is better than oral iron as far as increasing the hemoglobin level is concerned. But you don't need intravenous iron if you can salvage the situation with these two above. Now, still on alternatives to blood transfusion, I'm heading to erythropoiesis stimulating agents. Like I've just said a while ago, that kidneys will help us in producing erythropoietin. The erythropoietin will be needed by the bone marrow in production of blood cells. In chronic kidney disease, so the kidney is in trouble. That production of what? Of erythropoietin will be lost, or at least diminished. Then what will follow? There will be anemia of chronic disease. So examples of ESAs, that is erythropoiesis stimulating agent, will include Epres and the rest, including the generic erythropoietin, and is mostly given as international unit per kilogram intravenously or subcutaneously. It depends on which brand is available in your jurisdiction. Still on alternatives to blood transfusion, you may embark on preoperative autologous donation. What is that all about? Well, it's a situation where you have elective surgery and you have decided that, okay, my surgeon can take my blood, save it, and transfuse me with it when the operation is in progress or immediately after the operation is completed, if I should need blood transfusion. There are lots of situations associated with that. But I'm not going to that right now. I'll still go into that later on in the course of this presentation. And why will I skip it for now? Is gaining less recognition, meaning surgeons, doctors are not doing that so much anymore. Okay, another aspect of alternative to blood transfusion is cell salvage. How do I mean? The blood is collected during surgery. It is filtered and washed. Then it will be reintroduced into the same patient. So it's a kind of autologous transfusion, and it could be done intra or post-operatively. Still on alternatives to blood transfusion, certain medications could be useful, but it depends on the degree of anemia, the severity of the condition that warrants the particular product. So you may embark on the use of tranexamic acid, vitamin K, particularly a liver problem with vitamin K dependent clotting factors in trouble. You may grab desmopressin if it is von Willebrand disease or hemophilia A. Progesterone, women will understand that, uterine bleeding. Recombinant activated factor 7 in hemophilia A and B, and also F4 at early stages of intracranial hemorrhage. Early stages of intracranial hemorrhage, activated factor 7 will be helpful. Still, before transfusion, we must set the goal. We must aim at non-liberal, meaning we are not just going to get 5 units, 4 units, 3 units, 2 units of packed red blood cells with the aim of just transfusing a large amount of blood. No. We must embark on restrictive transfusion, meaning 1 unit at a time. Then we will examine the clinical state of the patient. If there will be any need for more, that determination will be made after being reviewed. Please don't assume. Just have the complete blood count or hematocrit taken, of the donor. I will share this, although to those in Western world, like Europe, North America, and so many parts of advanced Asia and some good centers in Africa, it will sound funny, but that is not the case in remote rural parts of the world. There was a case of a donor whose hematocrit was actually lower than that of the recipient. And the doctor made the determination the transfusion will not go ahead because it's not going to help the recipient in any shape or form. So, if you were laughing when you read this, you can now see where I was coming from. 1 unit of packed red blood cells is expected to increase hemoglobin by 1 gram per day. 2 hours after transfusion, please do one thing. Take the sample for complete blood count and hematocrit again. The goal of packed red blood cell transfusion is to reach 12 grams per DL for women, but I will not be stupid to tell you that you continue to transfuse and transfuse till you get this. No. You transfuse based on the need of the patient, okay? Like in cancer patients taking chemotherapy, why would I expect you to continue to transfuse from 7 grams per DL till you reach 12? That's not what I'm saying. No. But if you are lucky to reach this, you are done. Okay? Or in sickle cell disease patient, they don't even need to reach 12 grams per DL. They could adapt to low level of hemoglobin or hematocrit. Yeah. The same to men, 13 grams per DL will be fine. But I'm not saying you must continue to transfuse till you reach this level. No. Now, we will head to lab. All this before transfusion, right? In emergency situations, you may not cross-match. If that is the case, then you use O negative for women of childbearing age and all females that are children, okay? You can just go ahead and grab O positive for men, male children, and postmenopausal women. Surrogates, mothers, I said further explanation. When someone that is above childbearing age has been transfused and later on she chooses to be a surrogate mother, then that must be part of her history so that they will be able to make that determination right now whether she will be suitable for surrogate motherhood or not. Okay, we have to establish compatibility if that is feasible. If it's not an emergency condition, then we must group and cross-match and also determine resource factor status. Okay, still at the lab, we want to screen for infectious agents. HIV, hepatitis B, hepatitis C, malaria, and now COVID-19, and of course cytomegalovirus. Some will screen for babesiosis and so on, but depends on what is obtainable in your center. I remember a story. We were in the medical school and we were with our senior registrar in surgery, and then we're discussing about a particular procedure and the need for blood transfusion because there's that tendency for massive blood loss. And he turned to us and asked that we want to donate blood. We were all silent, and then he said, I won't blame you because I don't want to donate blood. And we said, why? Why not? And he said, and I quote, I don't want anybody to screen me for HIV. I don't want to know my status. Everybody busted to laughter. So whether you like it or not, if you want to run away from HIV screening, then you will not submit yourself for donation because you'll be screened for HIV. It must be done. Nowadays for COVID-19 also. And if you are in the tropical parts of the world where malaria is endemic, you must. be screened for malaria. And if you are coming or you are fresh from malaria endemic zone, you are now in the Western world, and for one reason or the other, you have to donate blood, you will be screened for malaria. So don't take offense, please. Depending on what is obtainable in your jurisdiction, if you have no blood bank, they will do it for you. But if you don't have blood bank and you are suspicious that the donor could have taken hard drugs or street drugs, like it's called in North America, please have toxicology screening done. Still before transfusion, we must do everything to guard against errors. What are we going to do? We must check the patient's identity, check the identity of the donor, establish that you are having the correct product as being prescribed by the physician. Is it a washed product? Is it irradiated? Is it whole blood, which is not commonly used anymore? Is it, some call it packed cell volume in some parts of the world, some call it packed red blood cells. Be sure you are getting the exact product. Cross-check the indications for the transfusion again and determine the dose and the rate, just to guard against errors. Somebody will say, oh my goodness, he has not even transfused yet. He's still talking about before transfusion. Oh, by the time we reach complications of blood transfusion, you appreciate what I'm doing. Because if you do all these things well, you will not run into complications. People are dying from transfusion of blood products. Prepare your own rescue kit. Oh, you see it now. Get your EpiPen. If you're in North America, that's what they call it. If you're in Europe, UK, and the rest is adrenaline. Get your corticosteroid, salbutamol, Benadryl, H2 blocker that's given intravenously, lysis, tranexamic acid, intravenous immunoglobulin. You can have that if you are from a rich center, right? Some, you could see that, I've highlighted this. Some will have acetaminophen and Benadryl administered before transfusion. It's even done in North America. Well, it is controversial. And why the controversy? What they are guiding against is febrile non-hemolytic reaction and mild, allergic reactions that they want to suppress. Yeah, but the argument against is that how about the side effects of these medications and even the toxicity of acetaminophen, hepatic necrosis and the rest like that. So, like I put it, it's controversial. Well, whether you have that or you don't have that, very soon we'll reach a state where you will need to use acetaminophen and Benadryl, and you'll still continue the transfusion. Lysis will be helpful just before transfusion by some people. Some will give it while the transfusion is ongoing. Some will give it post-transfusion, either way. Lysis is meant to prevent transfusion overload in elderly patients, in people with heart failure, in hepatic failure, in renal failure, and individuals with myocardial infarction. Lysis will help to decrease overload. To prevent transfusion overload further, if you don't want to use lysis, great, then do something else. Use only one unit. Is that okay? Review with the clinical state of the patient after. Then you may start the second unit if it is necessary. You may give more than one unit depending on what you're battling with. Okay, you may give more than one unit if you are battling with massive ongoing bleeding. No, the bleeding is still ongoing and it's very massive. Then, limiting yourself to one unit will probably not be helpful. Or you are dealing with a major surgery with the massive blood loss, or the symptoms of anemia you pick before transfusion is not improving with your 1 unit. Or there's bone marrow failure, and the individual having this bone marrow failure is having it because he or she is on chemotherapy. So what do you want to do? Indiscriminately destroying all growing cells. So you may give more than 1 unit. Or there is an existing cardiovascular disease. So under these conditions, you may give more than 1 unit, but I will still maintain my stand that you give 1 unit, then review with the clinical state. But going through this very slide, it means if you are faced with these conditions, you may let the blood bank be prepared for more than 1 unit from you. Okay, now you've made up your mind to transfuse. No alternative. You've known the number of units you may likely use. You've done your grouping and cross-matching. Everything is set. Then set the rate and time. Don't transfuse too cold, please. Why that? You run into arrhythmia, and that may kill the patient. You are trying to be good, you are trying to help, but then the patient is dead. Within 4 hours from the donor or from the blood bank, you should be done with your transfusion. Why that? When the blood is staying for so long, hemolysis will occur. Now, it depends if you are dealing with platelets, products, there may be aggregation. 1 unit over 1 hour if it is a case of blood loss. 1 unit over 2 hours if you are dealing with an individual with euvolemic status. 1 unit over 3 to 4 hours is very common. That is if it is very likely that there may be fluid retention. So you don't want fluid retention, you don't want pulmonary edema, you don't want cardiac overload, then give it slowly, 3 to 4 hours. Still before transfusion, someone will say, you should be done by now as per that. Oh, well, let's do it well. Preferring further transfusioning, because you don't want to go through the stress of transfusion, the complications, and the like. So look for, if you're able to find, address the cause of the anemia. Occlude any obvious bleeding, please. Like, it's not going to be helpful. This person is having internal bleeding from peptic ulcer, and you've not done endoscopy to clear the bleeding, ulcer, and you keep transfusing, and the patient will continue to come back. Look for any concealed bleeding, okay, like the example I've given. Make that determination. You are battling with megaloblastic anemia. Is it folate deficiency? Is it vitamin B12? If that is the case, replace as is appropriate. Right? Is this caused by alcoholism or poor diet? Find out and just fix that. Then iron deficiency, what's the cause? Now, is it because this person is young, needs more iron, or this person is losing blood somewhere? Is it because there's cancer somewhere, bleeding internally, or the diet is the problem, or malabsorption problem? Is taking good food, rich in fortified iron, yet not being administered? What is happening along the gastrointestinal tract? Now, find out why and replace appropriately. Are we battling with renal failure? Remember erythropoietin production. Erythropoietin is going to help the bone marrow to produce the blood. Now, the kidney is in trouble. The erythropoietin is not there. Then, refer to nephrologist to handle the renal failure while you can give your intravenous iron with erythropoietin. Okay? Is this a case of sickle cell disease patient? That's little you can do. Or thalassemia, refer to hematologist to handle those cases, because you may run to hemochromatosis. They always have excess iron in their system, and when you can't give them iron, you can't give them primary iron, then what are you going to do? You still need to help them. You know, in case of thalassemia, you do your phlebotomy. So we have to look for the cause and find a way to handle the cause to lessen the amount of times and the quantity of blood products will be given. So if you want to know more about sickle cell disease, you can click on all these links. To prevent further transfusion, we will address malabsorption syndrome. I alluded to that while explaining just a while ago. Is this celiac disease? No, irritable bowel syndrome, inflammatory bowel disease, Crohn's or ulcerative colitis. Do you have the medication to handle that disease, modifying anti-rheumatic drugs or the steroids? Now, is this a case of massive vomiting or inadequate intake or certain medications like ramphenicol in case of typhoid, in people with typhoid infection, given aplastic anemia? We just need to look for what is responsible for this anemia. Once we're able to get to the root and uproot it from the root, then we will do less when it comes to transfusion. Then there must be justification for the transfusion. In case of anemia, it must be anemia with symptoms and signs like syncope, presyncope, dyspnea, dizziness, chest pain, palpitations, or hypotension. Justification for the transfusion will include if hemoglobin is less than 7 grams per dl or less than 70 grams per liter, then transfuse. Yes, here, to all medical students and nursing students, if this comes up in your exam, the tendency to click on this will be great. Excellent. I don't fault you. I don't blame you. But you may not give packed red blood cells. You may give intravenous iron instead of transfusing packed red blood cells if you are battling with this hemoglobin level and the individual is asymptomatic, or the individual is not decompensating. So you don't have any, you are not under any pressure to get packed red blood cells right now. Even some centers, they are putting now as hemoglobin 6 grams per dl or less, then you must transfuse. So if you have 7 grams per dl and the individual is still asymptomatic, and somebody will ask me, how can you have this and the person will not be symptomatic? If it is not massive blood loss that is still ongoing, or this person is having sickle cell disease, they cope with low level of hemoglobin. If that is the case, then you do something else. But I'm not saying you should give intravenous iron to anyone with sickle cell disease, no. So anyone with this that is asymptomatic or not decompensating, and the person is young and has no symptoms, or is chronic iron deficiency anemia, go for intravenous iron. Okay, before transfusion, prepare yourself for perioperative transfusion. If it is a major or vascular surgery and you are envisaging a massive blood loss, you may not use the blood, but just in case, get ready, get at least a unit or two of packed red blood cells. Let the blood bank be aware that we are going for this vascular surgery or a major surgery that will likely lead to massive blood loss. When there is iron deficiency anemia and the individual is to undergo surgery, prepare for perioperative transfusion, meaning while the surgery is ongoing. you may need transfusion under the following conditions. You may not eventually need it, but it's better to be ready. Okay, now we're out of before transfusion. Now we're into transfusion proper, whole blood. Entire components of the blood will be in one bag and in citrate phosphate dextrose, and it will be transfused at once to one patient. That is what the definition of whole blood really means. Well, don't worry so much about that in advanced countries because it is rarely used nowadays. In other parts of the world, like I've said, my presentation is not meant for advanced countries alone, it's for the entire world. Where it is being used, please take all the necessary precautions. But if there's an ongoing large blood loss, like massive bleeding, road traffic accident, with no trauma, no fracture, and the bleeding is still ongoing, you can go for whole blood, even when you are in an advanced country. It is better to have whole blood separated into different products if you have the luxury and you have the time. Each patient will then receive exactly what is needed when it is separated into different products. Like I've said, some will need packed red blood cells, another will need only the plasma, another will need only the platelets, and another will need only constituent of the plasma like immunoglobulin alone. So that will help more. Without whole blood, there will be less reactions. Yes, because certain actions would have taken place. You would have removed certain antibodies, certain cytokines, and so many things would have been removed when you separate the whole blood into different products. And then there will be less overload. Remember, whole blood, everything is inside. The plasma, the red blood cells, the buffy coat, everything is inside. And you're sending everything into the system of the recipient. So there is likelihood of overload. Now, the plasma. The plasma could be obtained from whole blood donations or apheresis. Remember, we don't do whole blood transfusions anymore, but when there's whole blood donation, then it will be taken out of that. Remember the picture I showed you? The plasma will form the upper part, then the buffy cone, and below, the lowermost part will be the red blood cells. Preferably, obtain your plasma from men. Male donors are better. I'm not saying women are not better. No, that's not. No, I'm not saying that at all. But when it comes to plasma donation, we would rather have that from male. Why that? In women, pregnancy and alloimmunization is a big issue, right? Remember, there's that likelihood of antibodies being produced. And if the antibody is being produced because the woman is rhesus negative, and the transfusion has occurred in the past with sensitization, and then another child that is rhesus positive is now in the womb, then there will be problem. A lot of antibodies will be produced and so on. So that may be leading to transfusion-related acute lung injury. Why that? The lungs will be invaded by the immune cells, okay? And when immune cells are present in a region, they tend to lead to increased secretion in that region. So when they are present in the lungs, they will lead to secretions in that very lungs, okay? And then the lungs will become fluid-filled. Then when that is the case, there will be dyspnea, shortness of breath, respiratory failure, and of course, respiratory arrest, causing death. United Kingdom, they started the warning and they took proactive measures to prevent more trouble with transfusion-related acute lung injury, with female plasma donors. Although when it was public knowledge to other scientists across the globe, they did not receive it well initially, but later on, the right scientists saw the sources from United Kingdom, and today, in almost all the advanced countries of the world, they have restricted plasma donation to male donors only, so as to prevent transfusion-related acute lung injury. More work is being done in some other advanced countries on this very subject. So, thanks to women who have donated blood in the past and are still donating and will donate in future, but because of this problem, we will rather have males to give us plasma. Thank you to all women. So indications for plasma will include INR greater than 1.5. When you have that, it's tending towards bleeding. Also, in decrease, clotting factors 2, 7, 9, and 10 are written in this way because my presentation is not meant for medical students, nurses, and doctors only. Anybody who can come to my channel will have understanding. These are called vitamin K-dependent clotting factors produced in the liver. Actually, the liver produces all the clotting factors except 2. The 2 that will not be produced in the liver will be von Willebrand factor and factor VIII. But there is vitamin K-dependent clotting factors, and these ones are the vitamin K-dependent clotting factors. So when INR is greater than 1.5, that is why when INR is very high, some will give vitamin K. So we give plasma in that situation. When the liver is in trouble, we look for plasma. On anticoagulant but need surgery, if that is the case, you can get your plasma. When the person is breathing actively, you can get your plasma. When there's warfarin, but there's warfarin toxicity, or you need reversal of that when there's intracranial hemorrhage, or there's need in the case of acute major surgery, you can use your plasma. Still on indications for plasma, in disseminated intravascular coagulopathy, you may go for plasma, but first thing first, get to the root. You must correct the cause. A massive transfusion complication with bleeding. Of course, we don't do much of massive transfusion nowadays, but in case there is need for that, because we cannot shut our door that never will massive transfusion occur. What if it occurs? In that case, you can grab some units of plasma. In hereditary angioedema, well, there's a lot as per that, and I will not waste your time here because we still have a lot to cover. You can click on this very link if you want to know more about hereditary angioedema. Please click on this. This will take you to maybe 1 hour plus presentation on hereditary angioedema types 1, 2, and 3, and even the acquired. In replacement fluid for apheresis, grab your plasma. Radiation is not required because there won't be transfusion-associated growth versus host disease. Plasma derivatives. In this case, limiting this to human albumin solution. Here, there is no ABO group antibodies, no clotting factors, and no cross-matching is required. I'm talking about human albumin solution. It can be associated with a severe hypersensitivity. Please note that severe hypersensitivity is likely when you are using human albumin solution. Human albumin solution could be in form of 4.5 to 5% as strength, that is isotonic. And you will use this isotonic albumin for plasma replacement in burns, pancreatitis, trauma, and in plasma exchange. Now, I've just gone through the lower strength of human albumin solution, 4.5 to 5%, which is isotonic. Now, the other solution that could be 20% or 25% is hypertonic, okay? Unlike the isotonic solution, we will need this to initiate diuresis in hypoalbuminemia. And we can find hypoalbuminemia like in liver cirrhosis with ascites, in nephrotic syndrome, when you want your fluid in and out and you can't get the kidney to produce, and you are dealing with liver cirrhosis, then you just grab this hypertonic albumin to initiate that. Also in ascites with portal hypertension, and you've tapped, right? But you've tapped a large volume. If that has been the case, then you can grab your albumin hypertonic solution. Some would have used lases. You remember that portal hypertension with ascites will be sensitive to aldosterone antagonist. So some would have used spironolactone, and they would have used lases and would have used another diuresis, and they're not winning. So if you think you need to initiate diuresis, or you've tapped a lot, ascites tap a large volume, you can use human albumin solution. In newborn with a chain blood transfusion for hyperbilirubinemia, hypertonic albumin solution will be helpful. Prothrombin complex concentrate. This will be pretty useful in the face of liver failure with coagulopathy and also in warfarin overdose. Remember, we have clotting factors 2, 7, 9, and 10 that have vitamin K dependent clotting factors, all from the liver. Now the liver is in trouble as in liver failure, and warfarin is also working with vitamin K dependent clotting factors. So this prothrombin complex concentrate contains these deficient clotting factors. So it is better to reverse warfarin toxicity or overdose if you have the option of using either the frozen plasma or prothrombin complex concentrate. Go for PCC. It's going to help you more than frozen plasma. Here with prothrombin complex concentrate, you are going to be dealing with less cardiac overload, little or to non-allergic reactions, and the rate of thrombus formation is reduced. Now, immunoglobulins. You can get this from large pools of donor plasma. You may have intramuscular immunoglobulin for the treatment of hepatitis A, measles, or rubella, but the high dose will be intravenous immunoglobulin, and it's pretty obvious. All nurses worldwide know that when certain volume is reached, you can no longer give that medication per intramuscular route. That is why intramuscular immunoglobulin is not going to be large volume, but high volume, high dose could be given intravenously. So this will be helpful in replacement in immunoglobulin deficiency and in the treatment of autoimmune diseases. These will inform the reason why in the phase of myasthenia gravis, Crohn's disease, irritable bowel syndrome, so many autoimmune conditions where, like Kawasaki disease, where and when you can use intravenous immunoglobulin. Still on immunoglobulins, there are specific immunoglobulins from selected donor with high antibody levels to the target treatment. For example, in treatment of hepatitis B, rabies, tetanus, and prevention of rhesus D alloimmunization in pregnancy. Here you can have Roger or Winrow. Fresh, frozen plasma. Before now going deeper into this, I have my own personal observation and comment to make. I don't know if it's going to hold water anyway. I don't know what is fresh here anymore because very soon we are going to see that you can keep this for 3 good years, 36 months. So what is fresh here? And if a colleague of mine told me, they just want us to know that they obtain it fresh. But my question is, which of the products will not be obtained fresh? None, because you can't keep whole blood there for too long. The platelets will aggregate now, and the clotting factors, the plasma, will come up. So what are you telling me? So, okay, frozen at minus 25 to 26 degrees Celsius, pretty cold, right? Can be kept, or it's going to have shelf life of 36 months, that is 3 years. It is useful for reversal of anticoagulant effects, and it contains the clotting factors. So from henceforth, I'll be referring to it as frozen plasma. Okay, the frozen plasma must be thawed. Then the question from grade 3 is, if it is not thawed, how will you give it? Are you going to put ice blocks in human body? So definitely needless to say that it must be thawed. And I put a question here. Who will use it before being thawed? I don't know. Can be stored at 4 degrees Celsius for 1 day after being thawed. Okay? And it's needed for single dose use. Indications for frozen plasma. Clotting factors deficiency. Remember, all clotting factors are synthesized in the liver except for 2 of them. That will be von Willebrand factor and factor 8. The rest are from the liver. So when liver is in trouble, clotting factors are in trouble. Okay, and when someone is going to undergo liver transplantation or cardiac surgery, you can get frozen plasma. In DIC, acquired deficiency plasma exchange in thrombotic thrombocytopenia purpura, a warfarin reverser, but it is less used for this purpose nowadays. And why that? We have our PCC, prothrombin complex concentrate. It's helpful and better when compared to frozen plasma as per a reverser of warfarin. So prothrombin complex concentrate is more effective as an antidote to warfarin now than frozen plasma. It can lead to a very severe allergic reaction. As a matter of fact, the European Union is so concerned about variant Creutzfeldt-Jakob disease, and they are always working to a prime-reduced version. They do use methylene blue process to treat PACs from low Creutzfeldt-Jakob disease countries. So the European Union is working hard to reduce the variant of Creutzfeldt-Jakob disease through transfusion of frozen plasma. Some fresh frozen plasma are solvent detergent treated. For example, Autologous. Autologous will be stored for 4 years at minus 18 degrees Celsius. Oh, this is better than frozen plasma that must be kept at minus 25 degrees Celsius. Minus 18 degrees Celsius is okay for deep freezer, right? And you could keep it for 4 years. Wow. Now, packed red blood cells. I know, well, don't let me say I know, that would be affirmative. I could guess that many people that would have clicked on this very presentation would have done so because you are looking for a piece of information on red blood cells transfusion. Now you are there. Packed red blood cells, remember, whole blood transfusion is no more in vogue, okay? So packed red blood cells will be stored at 4 degrees Celsius and you could keep it for 35 days. Red blood cells in additive solution, okay? Most of the plasma is removed. When we are talking about red blood cells in additive solution, most of the plasma is removed. That is helpful to prevent certain reactions, right? And of course, that will make it packed red blood cells, okay? And what has been removed will be replaced by saline, adenine, glucose, and mannitol. Cycling. I have a separate presentation on mannitol already published. Then the red blood cells could be washed, could be irradiated. Packed red blood cells needed when hematocrit or total red blood cells are low, not in all cases of anemia. So we are not going to transfuse just everybody because we think they need transfusion. We will only transfuse them when they become symptomatic. And what are the symptoms we'll be looking for? Shortness of breath, exercise intolerance, dizziness, cramps in the muscles, altered mental status, angina, and congestive cardiac failure. Also, we will transfuse anyone with anemia when there's acute blood loss greater than 30% of the blood volume. In sickle cell disease patient with vaso-occlusive crisis or sequestration crisis, here let me explain further. Not all sickle cell disease patients that will need transfusion. While that, they can cope because they could adapt to the low hemoglobin level. But when they are faced with serious vaso-occlusive crisis, and of course hemoglobin will be low, and hemoglobin is low, then you can transfuse. But in sequestration crisis, that is a different ballgame entirely. In sequestration crisis, the spleen is mopping up the blood. The blood is trapped in the spleen. Then the spleen will become enlarged and there will be hypovolemic shock if there is no immediate intervention that could lead to death. As a matter of fact, you can take this from me. There was a case of a family that I knew of that needed to board flight across the Atlantic, and they have 2 kids with sickle cell disease. The brilliant doctor at the other end advised that they should have elective splenectomy. That was done. Why that? If they should go into sequestration crisis mid-air, well, on top of Atlantic, we don't know what that could mean. Still on indications for packed red blood cell transfusion back to sickle cell disease individuals, they can adapt to low level of hematocrit, good to know, but they will still need transfusion when they are decompensating. That means the anemia is becoming symptomatic, right? And they are in serious vaso-occlusive crisis or sequestration crisis. But there is a way out of sequestration crisis. You can have splenectomy done. So it's like repeating the previous slide, kind of. If that's the case, it means it's pretty important. In acute coronary syndrome, if the hemoglobin is less than 8 grams per dl, transfusion will likely decrease the mortality. Higher hemoglobin, hemoglobin greater than 8 grams per dl in acute coronary syndrome does not need transfusion. Because if you transfuse at higher than 8 grams per dl, you may likely tip the patient to recurring myocardial infarction, or you actually increase mortality in them. In thalassemia, we have to maintain hemoglobin that is going to be between 9 to 10 grams per day and at regular intervals proportional to phlebotomy. So if you have to transfuse, you watch the hemoglobin level and rate the rate at which you do the phlebotomy. So match that to whether you will need transfusion or not. But remember, they don't need our excess iron. Pre-op autologous donation. The other time I skipped this, now I'm back at it. Patient donates blood for his or her own use in a planned elective surgery. This is controversial, right? Because it's not acceptable in many parts of the world. It's good for people with rare blood types or certain plasma protein deficiencies. Certain criteria must be met before the individual could be eligible for pre-op autologous donation. The individual must sign informed consent and never collect blood within 72 hours of the surgery. And there's no age limit here, but the individual must be at least 50 kilograms or 110 pounds or bigger. Okay? Hemoglobin must be at least 110 grams per liter, that is 11 grams per day, or hematocrit at least 33%. Then further donation by the same person can be at 5 grams per liter less for hemoglobin or 1% less for hematocrit. Nothing more than 4 donations per a donor, and a week must exist between donations. You can give iron therapy to the donor after donation. So those are the eligibility criteria for pre-op autologous donation. But you may not bother yourself about this much because it is controversial and many centers are against it. There are certain contraindications to autologous donation, and that is we will not allow that in anyone with atrioventricular block or anyone with myocardial infarction in the last 2 months, anyone that is having ongoing infection or coronary artery stenosis, or anyone with ischemic heart disease, anyone with aortic stenosis or heart failure will not be allowed to make the autologous donation, or anyone with significant atherosclerosis or anemia that is not yet corrected. So with all those items listed, we will not allow autologous donation. How is it done? Well, the blood will be collected and put in an anticoagulant, that is CPD, meaning citrate phosphate dextrose, and then we'll get the red blood cells unit with plasma, leukocytes, and platelets reduced. Then you can get the plasma, if so requested, from the onset. So, and then you are going to suspend the red blood cells in solution of saline adenine glucose mannitol, and you can store it for 42 days. That is great, right? Though you don't need antigen antibody screening because you are dealing with the same individual, right? And you are giving it back to the same person, right? But you need the infection to be screened because you might be the one that will be sued later on if he or she develops HIV, hepatitis B, or hepatitis C, thinking that you were the one who mistakenly passed that to him or her. If autologous blood is syphilis positive, you can still give it to the same person, but should be indicated appropriately that, okay, we screened you and you are syphilis positive, but we'll transfuse you with it anyways. It came from you and it's given back to you. Any other diseases will make the blood unusable, like HIV, because you won't be able to explain later on when the patient will file lawsuit against you. Then how about associated complications? It can be mistakenly transfused with the wrong unit entirely, meaning you donated your own blood, it's been kept, but you are now in the department of surgery having your operation. The blood you've donated for your own use has been given to someone else and another one has been brought. That could happen, can be contaminated. Now, when you donate it, in the process of packaging and storing and transferring back for transfusion, there could be bacteria, fungi, or virus along the way. There may be circulatory overload. And do you want me to explain that? Yes, of course I do. Okay, you've donated the pack, it's already been kept in the blood bank. Okay, you've come back home. I'm talking to the patient right now that will embark on autologous donation, right? You've gone back home, you are taking good diet, everything is fine. Your blood that you've donated has been replaced because you have good diet and you're not losing blood. On top of that, because it's just the routine that you should be transfused with the blood you've donated, you are given extra. So more hematocrit, more hemoglobin is being added on top of your good value that is your system, so you can have overload. When it comes to packed red blood cell transfusion, we have the restrictive and liberal. Restrictive, we try to transfuse once hemoglobin is greater than 7 grams per dl to get to 8 to 10 grams per dl. The liberal, even when the person practicing restrictive is done, the liberal will just be starting. When the restrictive, this is not funny, but it sounds funny anyways. When, okay, two doctors, one is embarking on restrictive transfusion, okay, he or she will transfuse the patient from less than 7 grams per dl to 8 to 10, meaning he or she can stop at 9 grams per dl. That is when the guy with Libra will start. Will start transfusing at 9 grams per dl, meaning 7. Oh, the guy would have run up and down if he or she could see anyone with less than 8. So at less than 9, they will start transfusing, and the goal is to get 11 grams per dl. That is the difference. Let's talk more. The liberal transfusion will cost more money. More blood will be needed to be donated. More blood will be used. The tendency to have volume overload on the heart and lungs will be higher. There is no special advantage with liberal red blood cell transfusion over the restrictive. No special advantage. It is likely going to come down with more infections than restrictive. The restrictive, how you are. Somebody will say, oh, you are writing more because that's the one you like. And let's go through the content. Usually, you need just 1 unit per transfusion. And then, it's not like they're going to fold your hands, but they're going to open your brain, your eyes, and your ears to the nurses who will be with the patient to watch for the clinical status of the patient. So, if there's need for another, you give it. If there's no need, then you are done. Then another person can use the second unit. But in the Libra, you just keep loading, just keep loading. Jeez. So the restrictive will cost less. Imagine just needing 1 unit. Less blood usage. 2 patients will use 2 units. 3 patients will use 3 units. 4 patients will use 4 units. More lives will be saved. You see, 4 units for 4 patients, 4 lives will be saved with less volume per person. Less volume overload when you are given only 1 unit. Less pressure on the heart and the lungs. The giving of a large volume is not a special advantage. Well, might be to, I don't know, Is anybody still doing that anymore? I'm not sure, but if you are, please, my colleague, stop it. Libra is not advantageous. You may choose to give another unit after clinical review. Platelets. I'm going to start the journey with platelets on this note. First of all, determine the level of the iron. And somebody will ask me, what's your business with iron when you're about to address platelets? The reason is not far-fetched. Iron deficiency can worsen platelet dysfunction. So correct your iron, then come and grab the platelet. Stop all antiplatelet agents. Give tranexamic acid 15 mg per kilogram intravenously up to 2 grams when there is severe bleeding, or if there is a tendency to have severe bleeding. How can we get platelets? Platelets is produced by two ways. One is the pooled platelets, meaning the Buffy code from 4 donors. And you're going to put everything into the plasma of one of the donors. The other way is by apheresis, and that will come from just one donor. In this case, you're going to get less volume of platelets when you compare that to the pooled platelets. Remember, that's not too difficult, right, to figure out, right? Pooled platelets, you're talking about Buffy code from 4 different donors, and apheresis, you're talking about apheresis from just one donor. So when you are looking for large volume of platelets to be transfused, you rather go for pooled platelets. Or if you have many units of apheresis, but it means you're going to get it from different donors. So if you want just a small quantity of platelets, go for apheresis. So that will come from just one donor. Okay. Citrate phosphate dextrose is the anticoagulant chosen for platelets, but it could also be suspended in platelet additive solution after being washed to remove plasma. And last thing here is that you must agitate platelets. Why that? There is what you call platelet aggregation. Remember in clotting cascade, right? So we don't want that to happen. You can ask the people working there in different blood banks all over the world how they keep their platelet. It must be agitated. You can't just get platelet in a bag and leave it there. No, it will just form platelet aggregation, and you don't want that. Storage. How do you store platelets? The shelf life is just 5 days from the time of collection. But if you go to some literature, they will write 7 days. The reason why 7 days may be acceptable is simple, and it's just that if you don't have any other means to help this person, and the platelet you have is already 6 days old, you can still use it. But anything outside the 7 day, then throw it away. It should be kept at room temperature, between 22 to 24 degrees Celsius. This is the only product that will be kept at room temperature. The rest will either be refrigerated, deep freezer, or even lower temperature. It can lose function at fridge or freezer temperature. So clean environment is necessary, whether it can be contaminated so easily, and that will lead to sepsis, resulting in a very serious condition called fatal septic transfusion that will eventually kill the recipient. Okay, platelets have antibodies, like ABO group antibodies, but there may be no serious reactions or hemolysis. However, for you to have peace of mind that you are helping that patient and then you can sleep at home and your license will be intact, no legal action against you, why can't you have compatibility and incompatibility or whatever? Go through the grouping and cross-matching rules. Then you have your peace. In that case, Group O platelets should be given to blood group O. Then anyone with resource D negative platelets should be given to another recipient with resource D negative. You have your peace with that. If you are forced to give resource D positive to a young woman or woman of childbearing age with resource D negative, then you must give ROGA. This will help in emergency situations, okay? Don't give Rogan to men or any woman above childbearing age. You don't need that anymore. But you may choose your cutoff age, and when we say women of childbearing age could be 1. Maybe the woman has told me authoritatively that my large child is 20 years old, though I'm 45, and I'm not going to have any child anymore. That is acceptable. Or the woman has told me, I'm not going to give birth ever in my life, though I am 47. I'm not going to give birth anymore. That is great. Or the woman has told me, I'm now 55. In the last 3 years, I've never had my menses. So in that situation, then I can draw the line. But if this is looking like my grandma, I don't need to ask that question anymore. Indications for platelet transfusion. This is meant to prevent bleeding. The bleeding in what condition or conditions? In thrombocytopenic conditions, but not in all thrombocytopenic conditions. Will be comfortable to give platelets in non-immune thrombocytopenia. Also in platelet dysfunction, remember, I've said earlier, if there is iron deficiency and you've not corrected that, then don't give your platelets. If you give your platelets, then you will not be able to achieve much because iron deficiency will lead to platelet dysfunction. Thrombocytopenia due to bone marrow failure. If that is the case, find out what is responsible for the bone marrow failure. Then, in anyone with less than 10, don't ask me what I meant by less than 10. Nursing student, medical student, nurses and doctors, they do. If you are out of that, family, and you are listening to this presentation, that will be addressed by your physician or nurse practitioner. I don't want you to self-medicate. We will not give platelets or we will not transfuse platelets in heparin-induced thrombocytopenia, in thrombotic thrombocytopenia, in hemolytic uremic syndrome, or immune thrombocytopenic purpura. We will not transfuse platelets ordinarily. However, under certain conditions, we may transfuse platelets even in situations involving these. When would that be? Let's go. Still under indications for platelet transfusion when platelet is less than 20 or 20 on the dot, and the individual is about to have certain procedures like the placement of PICC line. PICC line is simply peripherally inserted central catheter. So a patient is going for PICC line and the platelet level is less than 20 or 20, you will still give platelet transfusion. Someone is about to undergo through ascendances, paracendances, or bone marrow biopsy or aspiration, then you must transfuse with platelet or endoscopy, because under these certain situations, there may be bleeding. Still on indications for platelet transfusion in neonates. Remember who neonates are? The kids delivered today until they are 28 days old. Did I say 28 years? That would be great, but that is not the case. From birth, day 1 to 28 days, those are the neonates. So if the platelet is between 20 and 30, and there's bleeding, or you need to do lumbar puncture, then before you do your lumbar puncture, then have platelet transfused. If you get the platelets in neonates from day 1 to 28 days of life, and it's between 30 and 50, then give platelets if the child is low weight, less than 1 kilogram, or there's intracranial hemorrhage, or there's coagulopathy, or sepsis or invasive procedures. Still under indications, if it's less than 30, but the individual is on anticoagulant that cannot be stopped, then you are going to the other side of serious bleeding, then give wonders. If it's less than 50, just because you say, oh, it's high already, or it's becoming high, but the individual must have life-threatening procedures, then give platelets. And ask me, can you give us the list of such procedures with platelets 50 or close to 50, and I must still transfuse the platelet? If the individual is to have lumbar puncture or vascular surgery, organ biopsy, deep access drainage, TIS procedure, in all these, please give 1 unit. Then you check the level before you have that procedure done. Okay, the platelet level is the neighborhood of 80, and you say, oh, that's not too bad, it's not scary, it's thrombocytopenia, but not scary. Well, still give 1 dose if there will be epidural placement or removal of epidural placement. So give it. Or it is in the neighborhood of 100. Oh, then I don't need to do anything here. Well, do something. You have to give at least 1 unit if there is a trauma or central nervous system hemorrhage or neuralgia surgery, and also in congenital platelet dysfunction. So other indications will be post-cardiopulmonary bypass and bleeding due to antiplatelets. Still on indications, in life-threatening bleeding conditions, remember the other time I said some of these will be contraindicated, but if there's life-threatening bleeding conditions, then with this, you can still give. Now, when it is greater than 100, mostly you don't need transfusion, but you need transfusion if the individual will undergo neurosurgery or ocular surgery. Now, contraindications to platelet transfusion. You've seen them again. I've said it already. Also, when platelets is greater than 100, you don't give. Intracranial hemorrhage that is not requiring surgery, you don't need to give. Okay. Note something here. I've said earlier that you are not going to transfuse anyone with all these conditions. No, I mean, we're not going to give platelets to them, right? But you can transfuse, even with this, if you are dealing with massive bleeding. But you can ask the question, Doc, why don't you like transfusing people with heparin-induced thrombocytopenia or hemolytic uremic syndrome or thrombotic thrombocytopenic purpura with platelets? Well, let me just tell you here that if there is massive bleeding, I will transfuse. But the reason why I don't want to transfuse is that all those conditions will form thrombus. Okay? And giving platelets will increase the chances of thrombus formation. Remember, platelets aggregation, right? So that's why I won't give it. And then in immune thrombocytopenic purpura, I will not transfuse unless there's massive bleeding. Why that? I just don't want to transfuse unless it is a serious bleeding, because the immune process responsible for immune thrombocytopenic purpura is not yet handled. Until that is handled, if I transfuse, that immune process will destroy the same platelets, those new platelets that I'll be sending into that same system. So I'm just wasting the money of the patient in countries where they pay. Even when government is paying, government is losing money. So you handle the immune process first here in immune thrombocytopenic purpura before you transfuse. And here, because you are afraid that thrombus will be formed, you don't want to give it. However, in these two separate conditions, against thrombus and against immune conditions, when you are not comfortable giving your platelet, if there's massive bleeding that may lead to death, giving platelets will likely still keep the patient with us than folding our arms. Now, side effects of platelets. Non-Hemolytic reactions, transfusion-related acute lung injury, transfusion-associated graft versus host disease, post-transfusion purpura that should be treated with intravenous immunoglobulin. Remember, that will be high dose. And then you contact your hematologist. Hemolytic reactions, septic reactions, allergy reactions, and febrile reactions. Delivery of platelets, specific blood-giving cells will be needed to deliver platelets. And in that case, the blood-giving cells with 170 to 260 micron filters or 20 to 48 micron microaggregate filters or leukocyte reduction filter will be needed. Only given as being compatible with normal saline only. So we will not give any medication or fluid through the same line with which we are going to deliver platelets. So only compatible with normal saline. Don't give any other medication through that line. Remember, you have to take vital signs before you give your platelets. Vital signs when platelets is not being transfused, that is during the transfusion, and you must take vital signs after the transfusion. You may inadvertently transfuse platelets with certain infectious agents, HIV, hepatitis B, Creutzfeldt-Jakob disease. Most people will spell it as CJD. Don't mind. West Nile virus, malaria in endemic zones, Chagas disease in North America, parvovirus B19, Lyme disease, and babesiosis. Platelets can induce HLA antibodies, so it is preferable to give HLA matched in those with persistent problems with random platelets. Why that? Because of the already induced antibodies from the previous transfusion. If the above is the problem or is the concern, then it is better to look for irradiated platelets to prevent transfusion-associated graft versus host disease. Or better still, give apheresis with platelet-specific antibodies negative. And then you can also use specific human platelet antigen that can be used for babies with neonatal alloimmune thrombocytopenia. Note this, hematocrit should be greater than 30% or hemoglobin should be at least 10 grams per dl. You may embark on the use of desmopressin if you are dealing with von Willebrand disease type 1 or the mild case of von Willebrand disease. If it is hemophilia A that is bind, or congenital platelet dysfunction, or in uremia with renal failure. If platelets is less than 10, then use platelets prophylactically if you are faced with hypoproliferative thrombocytopenia or there is thrombocytopenia with active bleeding, then you embark on treatment. Also in platelet dysfunction with active bleeding, embark on treatment. Platelet is given as one adult dose, which is equivalent to one Buffy cold pool. But a full dose should raise the value of platelets by 30 to 45,000. 1 hour after transfusion, please check the complete blood count of the recipient. From the complete blood count, you'll be able to see the platelets value. A Buffy cold pool is a pool of 4 donor units. No, I've just said that a while ago, right? While one apheresis is from a single donor. If a woman of childbearing age receives rhesus-positive platelets, then don't wait till you get sued or she runs into problem. Give Rogan. The brand name could be Winro. Why that? For allo immunization prevention. And you can go for 120 microgram. Please don't wait till future reactions before you act. Act right now. Rhesus positive platelet to a woman of childbearing age. Give Rogan. Except the woman is also rhesus positive. Half-life. Transfuse platelets half-life is about 2 to 3 days. So it is necessary to have redosing every 3 to 4 days if you are using it prophylactically. Now, wash platelets. By way of definition, wash platelets simply means you've washed these platelets. And what have you gotten rid of? You've gotten rid of proteins, antibodies, cytokines, metabolites, and so on. And here, you may use Buffy coat or use apheresis, okay? And then you wash. You may decide to use normal saline or citrate. When do we need that? Ideally, IgA deficient donors should be the ones that will donate the platelets to any recipient that is IgA deficient or in the normal situation, right? But when we have IgA deficient patient with antibodies to IgA, and we cannot get IgA deficient donors, then we must make use of the platelets that is available, right? Then we embark on washing. So we use washed platelets in that situation. Also, when there's anaphylactic reactions to platelet transfusion, and we've looked for the cause of that and we are not sure, we don't know it, or all we have left is washed platelets. When we have been faced with recurrent febrile, or allergic reactions, then we have tried to do everything, including plasma reduction, or we have used pre-medication, that will prevent the allergic reactions and febrile illness, like acetaminophen has been used, Benadryl has been used, yet we keep getting recurrent severe febrile or allergic reactions. With the transfusion of platelets, then we go for a washed platelet. Also, in fetal neonatal alloimmune thrombocytopenia, if the platelets will be required from the mother, then we have to wash it. In human platelet antigen, but you can use allogenic human platelet antigen matched platelet donors. Washed platelets must be administered within 4 hours of starting the wash. Then the washing procedure will take about 2 hours on its own. Then you can use plasma volume reduction. So those are the conditions when we will be fully determined to use only washed platelets. How about platelet concentrate? So here, the plasma reduction of platelets can be used before the transfusion of ABO incompatible platelets in a shortage situation, or to decrease the risk of isohemagglutinin, and to prevent hemolysis in platelet recipients. So, like the name is, platelet concentrate. In this case, plasma has been reduced, okay? Then we are battling with ABO incompatibility, right? But we don't have enough blood to transfuse. So we just remove the plasma, and then the rate at which agglutination will occur as a result of red blood cells will be reduced. So red blood cells hemolysis will likely drop in anyone that receives that. Cryoprecipitate. How do we get cryoprecipitate? First thing is we must have fresh frozen plasma. Remember that fresh frozen plasma will be stored at minus 25 degrees Celsius and could be kept for 36 months, that is 3 years. So at 4 degrees Celsius, then we can obtain cryoprecipitate. And it is necessary, or indications for the use of cryoprecipitate will include when we are faced with consumptive coagulopathy. Also, when there's massive bleeding, but this time around it's not just because of massive bleeding due to trauma, to cut, to anything else. It's massive bleeding that is secondary to the use of thrombolytic agent. How do I mean? Somebody is having maybe ischemic stroke or anything ischemic, and then you have decided to use thrombolytic agent, recombinant tissue plasminogen activator, and now there's massive bleeding. The next thing is to look for cryoprecipitate. Also, in low level of fibrinogen or dysfibrogenemia, or in von Willebrand disease, in hemophilia A, also in factor 13 deficiency. What are the possible contraindications to the use of cryoprecipitate? In sepsis, we will not use cryoprecipitate for treatment. It's not allowed. In fibrin glue preparation, we cannot use cryoprecipitate for this purpose. Still on cryoprecipitate, it is used when a concentrated product with less volume compared to the fresh frozen plasma is required. Okay? So the fresh frozen plasma, the volume will be bigger compared to using just an extract from it, that is cryoprecipitate. And cryoprecipitate contains fibrinogen. That is why it's helpful in low fibrinogen level or dysfibrogenemia. Also in von Willebrand disease, because it contains von Willebrand factor. That is why we can use it to treat von Willebrand disease. Also hemophilia A, because hemophilia A is a problem with factor 8, particularly factor 8 deficiency. That is why the presence of factor 8 in cryoprecipitate is helpful in treating hemophilia A. In neonates, factors 8 and 13. Remember, we use cryoprecipitate to treat factor 13 deficiency and hemophilia A deficiency. So in neonate, we can use cryoprecipitate to help them out of factors 8 and 13 deficiency. Also, in von Willebrand disease in them, and in congenital fibrinogen deficiency or congenital dysfibrinogenemia. You could see that going through this would bring it back to your memory the indications for cryoprecipitate. Now, the granulocytes. When we're talking about granulocytes, the main component will be neutrophils, and that is a phagocytic white blood cell. When do we need neutrophils or granulocytes? In cytotoxic induced, remember, cytotoxic induced. So, my friends, in oncology, we'll be familiar with this a lot. In cytotoxic induced prolonged neutropenia, in severe bacterial infection, in severe fungal infection. Remember, when someone is on chemotherapy, radiotherapy, and everything like that, and there's pancytopenia or bone marrow suppression, it's not going to augur well when the value of neutropenia is down. Neutropenia is a big problem, and then the people in oncology don't take that lightly at all. They always work against anything that will affect their patient that is neutropenic. So they will be supportive of this very page. In cytotoxic induced prolonged neutropenia, severe bacterial infection, severe fungal infection. Still on granulocyte, you can obtain granulocyte through apheresis after the donor must have been treated with steroid and granulocyte colony stimulating factor. Another way to obtain granulocyte is through buffycoat. Remember the picture that I've drawn earlier? You can click, pause, go back to it and look at it again. You're going to find plasma on top, the buffycoat in the middle, then the red blood cells down. So the buffycoat will contain the platelets and the leukocytes. Here, inside that buffycoat is the granulocyte. The reason why I'm making reference to that is that could be contaminated. The granulocyte from the buffycoat could be contaminated by plasma above or red blood cells below. Now, cytomegalovirus prevention during transfusion. This is pretty important. By way of brief definition, cytomegalovirus is a very large envelope double-stranded DNA human epivirus 5. That is cytomegalovirus. The possibility of a seronegative sample in window period is pretty possible. So, that has created doubt. Remember also the same is obtainable in HIV. In the window period, you are likely going to pick seronegative sample. And then some people are saying, doesn't matter, the fact that it is seronegative doesn't mean you cannot be transfused with cytomegalovirus or HIV when the sample is taken during window period. The best test is nucleic acid to cytomegalovirus. Clinical features. The clinical features here will be essentially that it could be asymptomatic, and that is the way it's going to present often. And when it presents with symptoms, the symptoms may be very mild, and the symptoms will be pretty close to what you can pick in infectious mononucleosis. So cytomegalovirus disease will occur commonly in immunocompromised individuals, and then that may lead to life-threatening pneumonia. It may lead to hepatitis, colitis, and it is also possible that you can pick congenital cytomegalovirus in the newborn. So when an individual has recovered, the individual will have IgG positive, or there may be cytomegalovirus seropositive at 6 to 8 weeks after contracting the virus. So the viral detection it's going to be found in the plasma during the window period of zero conversion in a rare occurrence. Later on, the virus will remain dormant in the white blood cells, particularly the monocytes. But there is that likelihood of reactivation later on in life. So it's fair to say that anyone who would have contracted cytomegalovirus will always have that cytomegalovirus in the body because of the dormant stage in the monocytes. So it can be contracted through blood transfusion, through breastfeeding, through saliva or urine, through tissue transplantation or organ transplantation, and it's going to be worse in immunocompromised individuals, in neonates, because they are just from day 1 to 28 of life, so the immunity is not yet developed, and it's going to be horrible in neonates with low birth weight. Since 1999, the scientists, particularly blood transfusion experts, hematologists, put us together that we've been facing this hurdle with cytomegalovirus, and then we must find out the way to prevent it altogether. So what we've done since 1999 is that they embark on a process of reducing the white blood cells in the products that will be transfused. So we call it leukoreduction. And with that, they have reduced the number or volume or level of monocytes. Remember, the monocytes is the hiding place for cytomegalovirus. That is where they will remain dormant and later on become active when, particularly when immunity is down, right? Or every unit with leukoreduction is started to be safe. Since that 1999, cytomegalovirus transfusion has not been completely eliminated, but it has been reduced. Okay, how can we say that these products I'm about to take or that I'm about to give to this man or woman will be cytomegalovirus safe? Number one, is it the product with leukoreduction? And if it is leukoreduction, at the same time, is it cytomegalovirus seronegative? Although you may be concerned about the window period, but if it is leukoreduced and cytomegalovirus seronegative, you can say, okay, I'm fine with this. But you can take a step further. Have you tested the cytomegalovirus with nucleic acid? So is it nucleic acid tested and cytomegalovirus IgG seronegative? If that is the case, then that is the best product to be used. Also, buffet cold platelets now is safe, so to speak, frozen plasma apheresis with leukoreduced platelets. The merits or disadvantages of irradiation of cellular component. There may be hemolysis of the red blood cells there, right? Then the cellular units are going to be modified. The antibodies are washed off. For example, immunoglobulin A. Okay. Other items that can be washed off are potassium, additive solutions, cytokines, and metabolites. Indications for red blood cells washing. Red blood cells with IgA antibodies should have the red blood cells washed. There's no need to wash donor's blood with IgA deficiency. If in the past the individual had an anaphylactic reaction or severe allergic reaction to a known agent during blood transfusion, then go for washed red blood cells. Or there's a variable allergic reaction to blood products in the past, then today go for washed red blood cells. You can have a washed red blood cells or plasma reduced red blood cells, or you prepare for anti-allergy. Apheresis, by definition, is just the removal of the old blood, and then you separate the old blood into its different components. So you are going to find red blood cells, platelets, leukocytes, plasma, all in different components. Once the desired component is taken, the rest will be put together again and return on into the system of the affected person. So this is pretty good. You are going for just one product. You take it and you put the rest back. Apheresis could be therapeutic plasma exchange, and that will be for the treatment of harmful substances found in the plasma. Remember from the word therapeutic plasma exchange. Helpful in immune thrombotic thrombocytopenic purpura. Also useful in anti-glomerular basement membrane disease. We are going to adopt this based on the assumption that the very problem that we have run into right now is antibody related. And we believe strongly when that has been done, we will get out of the problem. What are the possible indications for therapeutic plasma exchange? In thrombotic thrombocytopenic purpura, in Guillain-Barré syndrome, in myasthenia gravis, Gould-Pasteur syndrome, hyperviscosity, focal segmental glomerulosclerosis, ABO desensitization, in acute liver problem, in wheezing disease, that is excess copper accumulation, when we are faced with excessive IgG, IgA, or IgM, in acute inflammatory demyelinating polyradiculopathy, and the list goes on. Basically, in certain autoimmune conditions, when antibody is a big problem. The therapeutic plasma exchange will not come without a price. So, not the money per se, but the adverse reactions. We may be faced with hypocalcemia. Then there might be volume depletion, that is hypovolemia, with hypotension, muscle cramps, and headaches. There may be urticaria or rigors, and the cardiovascular system may suffer myocardial infarction, arrhythmia, or shock. The pulmonary system is not exempted from trouble because we face with pulmonary edema, embolism, or even pulmonary or respiratory failure. There may be hemorrhage or thrombosis. There may be infection with hepatitis, and some will actually come down with neurological issues like stroke or seizures. And we can't tell, maybe hypothermia. Still under apheresis, let's talk about cytopheresis. And how do I mean? When you have excess cells, like you have excess red blood cells or deformed red blood cells, you have excess white blood cells or particular white blood cells is giving you a problem, excess platelets or platelets is becoming the headache, then you can use this particular mechanism or method to remove the specific cells you want to get rid of. Yes, you can embark on erythrocytopheresis to get rid of red blood cells, leukocytopheresis to get rid of white blood cells. The same when you want to get rid of platelets. In fact, Photopheresis is used for cutaneous T-cell lymphoma. So you can go for specific cells and then get rid of them. Isn't that great? Now, let me go back to erythrocytopheresis, and let's go through certain indications for that. In severe malaria, wow, this will be helpful to those in the tropical world and in tropical medicine, particularly in malaria endemic regions of the world. You can embark on this and get rid of the plasmodium infested, plasmodium loaded red blood cells. Okay, in severe babesiosis, in sickle cell disease with stroke, or if you are trying to prevent stroke in sickle cell disease patients, if you don't know this, they are prone to having stroke. So we can use this method to handle that. In hereditary hemochromatosis, in fact, there's a separate presentation on hemochromatosis already published by me. And in polycythemia, when there is large red blood cells, particularly those in mountainous parts of the world, the mountain climbers, or people dwelling on places that are high altitude generally, and then if it is now causing problem, leading to hyperviscosity, then you can embark on erythrocytopheresis to undo that. Okay, there's nothing that has a good side that will not likely have the bad side. Let's see the possible bad sides or complications of apheresis. Here, you may inadvertently, you didn't plan it, but it's likely going to happen. Certain good items could also be removed while trying to remove that particular cell or cells you are targeting. Then you may run into volume overload or cellular losses with iron deficiency, and even your platelet level may drop if care is not taken, thrombocytopenia, leading to bleeding. Then how about those items that are already embedded in the blood that you may not be able to separate, and then you have to get rid of inadvertently at the same time, like calcium, iron, magnesium. And remember, when you are battling with hypomagnesemia, you are likely going to run to another problem known as prolonged QT. And when you have prolonged QT, you are going to have torsade point to ventricular arrhythmia, to ventricular fibrillation, asystole, and death. I've explained this countless times during the course of my many presentations right here on my channel. Also, part of the complications will be the result of the citrate that you're going to use. So you may run into citrate toxicity. And when you have that, you are going to have hypocalcemia. Having nausea, vomiting, chills. The muscle will start twitching. Some will have profound tightening, and maybe seizures. The heart will suffer arrhythmia. You have paresthesias and alkalosis. That is not the end of the road. Finally, part of the complications might include when you have removed large volume of red blood cells, you may run to anemia. And of course, the volume of the blood itself may drop, leading to hypotension, also hypovolemia. If care is not taken, you may even run to hypovolemic shock. And the individual could have syncope. And some individuals, if it's not likely going to happen, because if you want to embark on this, you would have prepared the escape route. That if I run into this, how do I get out? Because if you don't do that, then the patient may die. Now, transfusion complications generally, I'm assuming that half of the people that will click on this very topic right now on my channel will be here just because they want to find out about transfusion complications. Okay, if that is your goal, let's go. Transfusion complications or reactions may be acute. When we say acute, we're talking of within minutes of transfusion to 24 hours. It may be delayed. And let me say, most of the reactions that will warrant immediate action will be within the acute phase. It might be delayed. In that case, we're talking of what can occur days after transfusion, months after transfusion, or even years. Okay, mind febrile non-hemolytic transfusion reaction will be in acute phase. In fact, the transfusion will still be ongoing. Then the nurse will report. I've taken the vital signs again. It's like the temperature is rising right now, and is about 1 degree Celsius above pre-transfusion temperature. Then the question will be any rigor? The answer will be no. Any signs of allergic reaction, urticaria rash, anything? No. Any signs of anaphylaxis, wheezing, shortness of breath, swelling lips, and everything? No. Okay. Any sign or feature of transfusion-associated cardiac overload? No. Any sign of transfusion-related acute lung injury? No. How about transfusion-associated graft versus host disease? No. Any feature of hemolysis? No. Then the decision will likely be made depending on what is obtainable in your jurisdiction. Continue the transfusion. Please keep an eye. If you have been monitoring this patient every 30 minutes, I'm going to reduce it now to every 15 minutes. But we will not let the patient be there without any attention. We will give acetaminophen. I don't know the brand you may be calling it in your country or your jurisdiction. Some will call it paracetamol, some will call it Tylenol. And the Benadryl, that is amphetamine. As a matter of fact, some regions of the world, even advanced countries, they have a protocol where they will give acetaminophen with Benadryl pre-transfusion so as to prevent this mild febrile non-hemolytic transfusion reaction. Well, that is controversial to some. Some don't see the reason for that because they want to guard against the side effects of acetaminophen and probably that of Benadryl as well. Well, it's still debatable. So, besides the mild febrile non-hemolytic transfusion reaction, any other reactions that you deem to be moderate or severe, then there's a conventional way to deal with that. You are not going to continue that transfusion. First thing first, stop the transfusion. Check the patient, because that is the ultimate goal. We want the patient to be well. Then stabilize the patient, depending on what the problem is. Notify the patient of what has happened, or the substitute decision maker when the patient is not the one taking the decision anymore. We must not keep that to ourselves. Then we have to remove the blood, including the given cells, and send to the blood bank. We will send the blood back to the blood bank. Immediately, we will administer the appropriate medication from the kit that we've kept. Remember, when I was going through before transfusion, please have a kit. And I've given you the list of certain medications that may be inside that kit depending on what is obtainable in your jurisdiction. So we will then open that kit right now. EpiPen, corticosteroid, Benadryl, salbutamol, IV fluid, tranexamic acid, intravenous immunoglobulin, lysis, acetaminophen, as the case may be. So you use appropriate item based on the type of reaction on ground. Okay, we are still on reactions to transfusion, right, or transfusion complications. Let me advise myself and all my colleagues, don't rush that blood into that particular man or woman. Whether massive or rapid transfusion will lead to arrhythmia, fluid overload, heart failure, hyperkalemia, hypothermia, hypocalcemia, pulmonary edema with dyspnea, if care is not taken, cardiorespiratory arrest, and death. Under acute complications, when we have the following reactions, they are non-infectious, and that would be as a result of using wrong blood. So agglutination is non-infectious, allergic reaction is non-infectious, where we see urticaria under allergy is non-infectious, and acute hemolysis, acute may not be because of infection. Still under acute complications and non-infectious is anaphylactic reaction. So allergy, anaphylaxis, coagulation problems, particularly when you are giving massive transfusion. That is why we'll still go back to restrictive transfusion is the best option. Give 1 unit, review the clinical state or status, then give another if it is so required. Also, febrile non-hemolytic reaction that I've gone through. You may not stop transfusion because of that. You can give acetaminophen with Benadryl. Metabolic disorders. Now, allergic reactions. The allergic reactions could be mild. And when it is mild, it's going to be with urticaria, pruritus, or hives. Bad may be life-threatening with anaphylaxis. It's not that I like mild allergic reactions with urticaria, pruritus, or hives, but I prefer that. I hate anaphylaxis because anaphylaxis can send the patient to the grave so quickly. So with anaphylaxis, there will be shortness of breath. Check the leaves. It will be swollen. Hypotension, stridor, hives, rashes, anaphylactic shock, and possibly death. So we quickly act and act very, very fastly. Still on acute complications, there's a piece of advice there. Don't confuse the swelling you are picking right now that may be due to allergic reaction to angioedema. It may be anaphylaxis with swollen leaves, but you are not going to pick urticaria in angioedema. It's going to be bradykinin, induced. Okay, so we see one esterase inhibitor deficiency. Okay, either functionally or quantitatively. There are 3 types of angioedema. Angioedema could be acquired angioedema or hereditary angioedema. The hereditary angioedema will be hereditary angioedema type 1, type 2, and nowadays we are getting the 3rd one, type 3. Okay. Here, the triggers will include infections, hormonal use, stress, trauma, or certain medications. What are the possible clinical features of angioedema? It could just occur suddenly. So there may be no trigger or triggers. That's why I said be careful before you run into trouble that, oh, this is transfusion related, and then you'll be loading with EpiPen, you'll be loading with corticosteroid, and you are not winning because you're not going to win. You are not going to win. Angioedema is not going to be responsive to your EpiPen or adrenaline or corticosteroid. No, it's not going to work here. So the swelling there could be any part of the body, facial swelling, that can be hidden from people, can affect the oropharynx and obstruct the airway. That may lead to death. Okay? And both respiratory oropharynx region could affect gastrointestinal tract, leading to intestinal obstruction with nausea, vomiting, diarrhea, abdominal pain, and some people will even have weight loss. It is not allergic. It is not anaphylactic. But you will not see urticaria, and it's slowly progressive. Okay? So there's no fixed pattern here that I'm going to get when it comes to angioedema. And swelling will be increasing within 24 hours. Over days, even when you don't use anything, it might be resolving. But that's why I'm bringing it here. You can overdo whatever help you want to render. But one good thing with angioedema is, even with your zeal to give corticosteroid, to give EpiPen or adrenaline in Europe, EpiPen in North America is the same. So even when you give that, you give your Benadryl, you give everything, you're not going to win. But there will be no urticaria. So don't let me waste all your time here. If you want to know more about angioedema, hereditary types 1, 2, and 3, and acquired, click on these links. Now, the prevention of allergic reactions. This will occur when IgA deficient patient receives IgA with anti-IgA, or there's anti-HLA and anti-complement. So, don't give plasma that is rich in IgA to a recipient with IgA deficiency. Instead, kindly let that product be washed and keep an eye on the first 15 minutes of transfusion. The nurses are pretty good. They are doing that. More kudos to them. Acute hemolytic reactions might be immune or non-immune. So it might be intravascular. In that case, it will be ABO antibodies not related, or extravascular. In that case, it will be IgG or complement related, that will not be within the vascular system, but in liver or spleen. Acute hemolytic reactions could be immune-mediated within 24 hours. And that will be as a result of destruction of the transfused red blood cells. Here, the recipient's antibodies will attack the blood from the donor. Here, the issue is about ABO antigen antibody problem. Alloantibodies to other red blood cell antigens have been developed after this individual had been transfused in the past or due to pregnancies. Acute hemolytic reactions may be non-immune, and when that is the case, it could be caused by bacterial overgrowth, improper storage. And remember that I've gone through how you can store each of these products separately. It might be as a result of incompatible medications, or you are using a very small bore IV lines that is now leading to hemolysis of the blood product, particularly red blood cells. Or you are using hypotonic solution, and you know what that means. There will be movement of solids from area of lower concentration to area of higher concentration. You remember osmosis in biology, right? And then there'll be swelling, and then, you understand what I'm talking about. Now, back to acute non-hemolytic reaction, specifically febrile non-hemolytic transfusion reaction. Why did I say back to? Remember, I've mentioned this earlier at the beginning of complications of blood transfusion or blood transfusion reactions. But remember, I stated then, mild febrile non-hemolytic transfusion reaction. This time around is more than just being mild. Okay, this will occur within 24 hours, like I said earlier, and the rise in temperature is not that scary, something about 1 degree Celsius above 37. But unlike the other time when I said there'll be no rigor, no chills, here there'll be rigors, there'll be chills. In fact, there'll be discomfort. And this will be a diagnosis of exclusion, meaning we would have ruled out other causes of all these conditions before settling down with febrile non-hemolytic transfusion reaction. And the patho here is essentially that we'll be dealing with cytokines and pyrogens. But I've written it there that I'll give further explanation. This is likely going to be common in pregnant women. It can occur in anybody, but more in pregnant women. We will run into this when there's history of repeated transfusion. But kudos to the experts in blood transfusion. That is reducing nowadays because of the possibility of leukoreduction products. So when there is leukoreduction, then the rate of febrile non-hemolytic transfusion reaction will drop. We will run into febrile non-hemolytic transfusion reactions more when we transfuse platelets than when we transfuse packed red blood cells. The cytokines here will be interleukin 6, interleukin 8, and tumor necrosis factor. Okay? And the antibody-mediated endogenous pyrogen will all join hands to lead to the febrile condition, giving us rigor, chills, and discomfort. Now, TRALI, that is transfusion-related acute lung injury. It is a non-cardiogenic pulmonary edema, okay? Meaning, the problem is not because there is right heart failure or left heart failure, backflow, or whatever. No, that's not the problem. The problem is it is non-cardiogenic, but there's pulmonary edema. Then how? Okay, let's go. This is a diagnosis of exclusion. We've ruled out other possible causes of pulmonary edema, right? Here, there will be acute hypoxemia, for obvious reasons, right? Because there's already pulmonary edema, fluid is occupying the lungs. This will occur within 6 hours. It's more likely if we are dealing with a plasma from a multiparous woman. So the donor of the plasma is a woman, and she is a multiparous woman. Well, I respect all women worldwide. In the past, the brilliant, United Kingdom blood transfusion experts decided to stop getting plasma donation from females. They said that from henceforth we'll be taking plasma donations from male donors only. Well, initially that was not welcomed by everyone. Of course, you understand, right? People will say, well, what? Are you discriminating against women and so on? That was not the case, because they will take that plasma from male and they will use it to help females out of their problems. So how are they discriminating? That was not the case. Later on, other scientists from other advanced countries and the less advanced countries saw a big sense in what the UK blood transfusion experts suggested or they started doing. And then they saw that the rate of these transfusion-related acute lung injury was coming down when they limited plasma donation to male donors only. Why did we run into problem with female or pregnant women or multiparous women donation? Pregnancy and alloimmunization is a big concern when the antibodies produced may be transfused with the plasma, leading to transfusion-related lung injury. Okay? Here, the lungs will be invaded by the immune cells. The lungs will be invaded by the immune cells. And what are those immune cells? The anti-neutrophil cytoplasmic antibodies or anti-HLA antibodies will invade the lungs. Then the recipient immune system will be activated. Then tissue damage will occur from the activated neutrophils in the lungs, leading to lung secreting proteolytic enzymes. So there'll be massive secretions in the lungs, and the lungs will become filled with fluid. And then we will run into the cascade of events like shortness of breath, dyspnea, respiratory failure or respiratory arrest, and possibly death. So more under brilliant blood transfusion experts in all other countries started working on this. In fact, some are getting more fast right now that will be published later on. Now, transfusion-associated circulatory overload. Here, we will run into circulatory overload when large volume is used than the volume required. Let me explain what I meant. When 2 units are required and you give 2 units, it's not likely that you have circulatory overload because you are not giving more than what is needed. So where would the overload come from? But if you embark on the restrictive transfusion, and under the situation where and when you use only 1 unit, and then you review the clinical status of the patient, and you give more if so required, then you are not likely going to run into this. And some people will actually give lases and then start the transfusion. Well, also when you transfuse faster than the rate expected and the heart could not cope, you have circulatory overload. Here we are not having any issue or issues with antibodies. No way. No antibodies right here. I mean, it's not a problem related to antibody. The transfusion-associated circulatory overload might be as a result of pre-existing conditions like cardiovascular disease. So we need to know. That is why we said if you are going to transfuse somebody with heart failure, then you are not going to give so large volume and you're not going to rush it because the heart is already in trouble, right? And somebody with renal failure, the liver, the kidney, the heart, they handle the fluid together. That's why ascites could be hepatorenal, and then portal hypertension, there could be outflow in the heart and back and forth. They are all handling the fluid together, right? And it might be pre-existing condition involving anemia, or someone that is too young or too elderly. In all these conditions, you can do one thing and you don't even run into any problem, even with the pre-existing conditions. And that is, we just give 1 unit at a time. and then watch. If they give more, if so needed. The clinical features of transfusion-associated circulatory overload will include tachycardia, cough, dyspnea, hypertension, increased central venous pressure, increased pulmonary wedge pressure, wide pulse pressure, cardiomegaly on chest X-ray, that is if it is long-standing, pulmonary edema from auscultation and from X-ray and everything. But if you want to know more about congestive cardiac failure, where you can understand all these features better, you can click on this very link. Now, how can we diagnose TAC, that is transfusion-associated circulatory overload? We can make that diagnosis clinically by taking a thorough history. Here we are talking about transfusion-associated, right? So history of blood product transfusion. You want to know the volume of the product, the exact product, then when was the transfusion? And then we want to know about the clinical state of these patients before transfusion. Any cardiovascular disease before now, anemia, and so on. And of course, we embark on general physical examination, general inspection. We will auscultate as is appropriate, percuse as appropriate, palpate as is appropriate. And then we can do certain investigations like chest X-ray. We just want to be sure, right? Then something definitive will be done. We'll head to the lab. There are so many things we can do in the lab, but we will not forget to have brain natriuretic peptide level assay. That will distinguish TACO, transfusion-associated circulatory overload, from transfusion-related acute lung injury. BNP will distinguish that. We've been talking about cardiac asthma, bronchial asthma, they're not the same. Here, Trali and TACO are not the same. The BNP will give us more clue that no, this is not a problem limited to the lungs, coming from the lungs and restricted to the lungs. It's a problem coming from trouble in the circulatory system, affecting the cardiovascular system, affecting the heart. Well, if you want to know more about BNP, I have a full presentation right here when it comes to BNP, including Entresto, and how that could affect the value of BNP and pro, anti-BNP and so on. Click on this and you get that piece of info. Okay, how do we prevent TACO? First thing first, we will advise ourselves, don't rush. Don't rush blood transfusion. No. You are trying to save the life. We will not send the man or woman to early grave. Don't rush. Don't give too much. Go back, rewind, get my comment on restrictive transfusion. That is the best. Kudos to those who invented that, right? Just give 1 unit. Wait. Check. Then decide to give another if that is the case. Don't give too much. Adopt the non-liberal transfusion. There you go. Just give 1 unit and review before you give another. That will prevent TACO. Now, delayed complications. We'll be dealing with transfusion-associated graft versus host disease. Or some will write it this form, depending on where you're getting your piece of info from, here we'll be battling with iron overload, delayed hemolytic reaction, post-transfusion purpura, transfusion-related immunomodulation, and infections. Transfusion-associated graft versus host disease could be prevented if we embark on irradiation of blood components. When we irradiate blood components before transfusion, that can help in preventing TAGVHD. The brief explanation that I can give is that the donor's lymphocytes will proliferate and can cause an immune attack against the tissues and organs of the recipients. Later on, we will see the tissues and organs that could be attacked. Okay? Well, the light at the end of the tunnel here is that it is a very rare condition. It's a very rare condition, but when we are going to find a few cases we are going to find, if we don't have preventive measures, then in anyone with immunocompromised state, we may run into trouble of transfusion-associated graft versus host disease. And when we run into that trouble, it's a big one. It's a very serious trouble with high mortality or fatality. It could be as high as 80% in anyone affected. As a matter of fact, some literature will put it as high as 90%, meaning 9 out of 10 blood donation recipient or blood product donation recipient that will react and have transfusion-associated graft versus host disease, 9 out of 10 will likely die. So putting it as 80 is even now small. So it's a serious issue. Must do everything to prevent this condition. What are the possible risk factors here? Direct donation from family members with shared halotypes. Newborn. Remember, newborns, they don't have good immunity because it's not fully developed. And the newborn is now having cardiac-related anomalies. Then there is the need to have blood product transfusion that is not irradiated. Then we may run into this. When HLA is matched, meaning they have the same HLA from donors to the recipient, just like family members sharing halotypes, then we are in trouble. Immunocompromised conditions. Recipients that have been on chemotherapy for a long time with immune state being compromised right now, or someone on corticosteroid for a long time, the diabetic patient that has been suffering for a long time with immune compromised state, or someone with HIV, AIDS, or somebody on disease-modified anti-rheumatic drugs, all conditions that could lead to immune suppression. And then we transfuse without irradiation. We may run into this. Intrauterine transfusion and until gestational age of 40 weeks may lead to possible TAGVHD. Newborns with exchange blood transfusion may come down with this. Still on risk factors, Hodgkin lymphoma or hematological malignancies generally, solid tumors already treated with cytotoxic agent. Remember, when we are dealing with oncological cases, one thing is pretty common to everyone there, immune suppression. Certain medications like fludarabine. Fludarabine is a chemotherapy, okay? And hematopoietic stem cell transplant recipients. All these conditions will lead to immune compromised state, right? DIGER syndrome or severe combined immune deficiency or cell-mediated immune deficiency or prematurity with low birth weight. All these will be risk factors for transfusion-associated graft versus host disease. Now, T lymphocyte is responsible, but the dose is not known. Let me explain what I'm trying to say here. We are sure the problem is due to lymphocytes, but we don't know whether we need to have a large, volume of T lymphocytes before we run into this trouble, or small quantity of lymphocyte will suffice to lead us to this trouble. We don't know. Just as the case is with fetal alcohol spectrum disorder, where the quantity of alcohol is not the determinant of whether the child will eventually come down with FSAD or not. So the pregnant woman is constantly being admonished, encouraged, advised not to take alcohol while pregnant, because the quantity of alcohol is not what we could measure as being proportional to the degree of fetal alcohol spectrum disorder or not. The same is here. We know it is T lymphocyte trouble, but we don't know whether we deny high or small level of it before we have the problem. What are the possible clinical features? The clinical features will be non-specific, but it is sure we're going to be dealing with bone marrow failure at the first week of this trouble, and at the fourth week, when the bone marrow would have failed, then we'll be running to pancytopenia. Then there'll be diarrhea, hepatitis, rashes, and fever. That, due to transfusion-associated graft versus host disease, will be largely due to pancytopenia that is associated with bleeding and infection. You all understand what pancytopenia is all about. All blood-forming cells are underperforming. We're talking of anemia, talking of thrombocytopenia, talking of leukopenia. Everything is penia. So that is why bleeding will come from thrombocytopenia. And of course, anemia. No, anemia is not causing bleeding, but bleeding can cause anemia. And thrombocytopenia will cause the bleeding. And of course, infection from leukopenia, right? Neutropenia, everything penia. So the target organs here will be the skin, the bone marrow. The bone marrow failure will lead to pancytopenia. The gastrointestinal tract, where we're going to find extravascular issues like liver and intestine being affected. How can we make diagnosis of transfusion-associated graft versus host disease? We have to assay for donors T lymphocytes in recipient's blood. Then we will know. While trying to do good, helping to save the life of this man or woman, we have inadvertently introduced the T lymphocyte from donor that is now punishing the tissues of this recipient, the skin, the gastrointestinal tract, and so on, right? Okay, then we can embark on skin biopsy for pathological studies. Okay, how are we going to treat transfusion-associated graft versus host disease? There's no definitive treatment, so all we have left is supportive. Remember, I have stated earlier that the mortality here is pretty high. In fact, some authorities would have put it as 90%, meaning 9 out of 10 people diagnosed with this will end up in the grave. Wow. Very horrible, right? Because we have no fixed, definitive treatment that is effective. None. It's only supportive. It could be cured, however, when there is that possibility of very rapid hematopoietic stem cell transplantation. Remember, bone marrow issue is the major concern. Although there will be problem with the skin, with the liver, but the bone marrow that will be affected is the major issue that will lead to pancytopenia. With pancytopenia, all blood cells will be underperforming. All precursor cells will be underperforming. So less of leukocytes, leading to more infection, including neutropenia. Less of platelets, that is thrombocytopenia, leading to bleeding and anemia, and that is what is killing. So if you can get the bone marrow transplanted, then great. Prevention is better than cure. And how do we do that? By irradiation of the components that we need to transfuse. So still on prevention, that is better and cheaper than cure, because it's even not curable, except we have emergency hematopoietic stem cell transplantation. We will not get out of it. So if that's the case, we are left with one option: preventive measures. Okay, let's have irradiation of the following: whole blood, washed red blood cells, platelets from body codes or from apheresis. Cellular units donated by family members should be irradiated. Granulocyte concentrate should be irradiated. And HLA matched platelets should be irradiated. Okay, I've decided to sum the non-infectious complications of blood transfusion up right here to include iron overload. Well, someone would like to remind me of hemochromatosis, right? Okay, I have a separate presentation on hemochromatosis, and it's already been published by me. Here is the link. If you want to know more about hemochromatosis, kindly click on this very link. Also, may be battling with delayed hemolytic reaction or post-transfusion purpura. We've just gone through transfusion-associated graft versus host disease that will affect the skin, the bone marrow with pancytopenia, and the liver or intestine, leading to death in about 90% of affected people. Also, transfusion-related acute lung injury, when we will be making use of male plasma donors only, and we will try to encourage the female donors that will need their blood products for something else, but not plasma transfusion. In transfusion-associated circulatory overload, remember, you don't rush and you don't transfuse too many units at a time. And also, we need to find out the underlying cardiovascular problems in this individual. And we've already gone through that BMP will help us to distinguish TACO from TRALI. Also, transfusion-related immunomodulation, anaphylaxis or allergic reactions cannot be overlooked, because this will happen pretty quickly while the blood transfusion is still ongoing most of the times, or within 15 minutes post-transfusion. So the anaphylaxis could lead to death. And that is why we need to get a kit containing EpiPen, corticosteroids, Benadryl, salbutamol, H2 blocker, and some we actually give Benadryl and acetaminophen before transfusion. And also, we've gone through febrile non-hemolytic transfusion reaction that we characterize with fever, rigor, chills, and the like. But in mild febrile non-hemolytic transfusion reaction, there will be no chills, there will be no rigor, the temperature will just be above the baseline by about 1 degree Celsius. In that case, you just give acetaminophen and Benadryl and transfusion can continue. And the list goes on. Now, infectious complications of blood transfusion. Inadvertently, hepatitis B and C could be given to the recipient from the donor. Well, someone will ask, will you people not screen properly before you transfuse? Remember, my presentation is not meant for advanced countries alone. It is for the entire world. So many people that will be able to understand what I'm talking about in English. And to those who help in translating, you're welcome. So it's possible. And when that is the case, it means the recipient has entered a new phase in his or her life. Because of chronicity of these viruses, particularly hepatitis C, and then the probability of going down the hill to hepatocellular carcinoma. HIV. There is a very horrible story of a particular private practicing physician with one big hospital in a particular center and in one part of a big city in the world that inadvertently transfused the patient with HIV virus. Well, the patient eventually was traced to the hospital. Well, the doctor was summoned by the disciplinary body of the medical body of the country, and the doctor couldn't withstand what was going on. Well, long story short, committed suicide. So it's a true life story anyways. So not only in recipient that trouble could be, it could also be in the physician in charge or the nurse practitioner who took that decision. So it's a serious issue. HIV must be properly screened. We should never give any blood without knowing the status of hepatitis and HIV viruses. Nowadays, COVID-19 also. Human T lymphotropic virus 1 and 2. Malaria could be involved, particularly in malaria endemic zones of the world. And you know what? If you transfuse Plasmodium falciparum, then there'll be more problem. In babesiosis and West Nile virus, Creutzfeldt-Jakob disease. If you want to know more, I'm sorry that I wrote it this way, it should be CJD. And even some will put variant Creutzfeldt-Jakob disease VCJD. But anyhow, just write it anyhow. You understand what I'm talking about, right? And if you want to know more about Creutzfeldt-Jakob disease, you can click on this very link. I have a full presentation on Creutzfeldt-Jakob disease already published by me, and this link will lead you to that. And also, like I've said, HIV/COVID-19 must be ruled out before loading the recipient with our blood. In conclusion, the importance of blood transfusion cannot be overemphasized. In fact, hardly would any physician pass through the medical school, the residency training, internship, practicing life without going through one way or the other blood transfusion issues. I'm not saying one issues. Some believe that blood means life. Are we going to dispute them? I don't think so. Massive blood loss will be equal to death if no blood transfusion quickly enough. So, is that not corroborating or buttressing the point that those who believe that blood means life, they're not wrong? I started with right product to be given to the right person, at the right place, at the right time. But let me conclude with right product to be given to the right person, at the right place, at the right time. And I'm going to add through the right route and give the right dose and the right rate. With that, I've come to the end of this long presentation as per blood transfusion. This is A to Z of pieces of info on blood transfusion. Long live the medical service to humanity. Thank you. Please remember to subscribe to my channel. Remember to share this representation on your platform with all your friends. I appreciate it.